position. As I can see, there are people from the ministry, there are people from non-government organization. That sensitization can be done, but it is not a one thing or one person can say, tomorrow I will go to talk to the police force to reduce harassing. It is a step by step, and it needs to follow some procedures to be taken. But I think everyone has taken it in board, and if you have that, opportunity, you can sensitize about that. But it is true, some are affected. Thank you.
Thank you very much, Noella. I think we can give another round of applause.
We are now going to hand over to Dr. Kantata Simwanza, who will take us to the panel discussion and continue on from there.
Jamani, habari ya mchana. Hebu naomba tusimame. Simama. Nikisema sergeant mnasema sapopo. Sergeant. It's like do what I do. Yeah, you see? Sergeant, sapopo. Sergeant. Sergeant. Hello? Yeah, you may get seated. Okay, so you are welcome, and thanks God up to this moment, we are still doing fine. So for the second panel, we are going to have different speakers, and we'll be speaking on strategies on ensuring we are how to better reach key and vulnerable populations, and strategies to increase their treatment adherence. So for this panel discussion, our panelists are going to be as follows. So we will have Dr. Isaac Maro, who will be representing researchers in the country. Dr. Isaac Maro is a research fellow at Tokyo Medical and Dental University. Currently is based in Tanzania. Dr. Maro, karibu sana hapa mbele. Can you applaud him? So our second panelist will be a youth representative, Josephine Nabukenya, Kenya, IAS Governing Council. She's coming from Uganda. Karibu, Josephine. Where is she? Oh, Josephine, please, Karibu. And the third one will be a government representative, Dr. Samuel Nsumba. He is coming from National AIDS Control Program for Tanzania. Karibu sana, Doctor. My brother. Yeah. From TACAIDS, please. From TACAIDS. Sorry, from TACAIDS. You know, TACAIDS and the NSP. Wanafanana. The fourth panelist. So the first panelist will be Arnold Nicholas. He is representing a Forum Tanzania, and is coming from Tanzania, Maryland. And our fifth panelist will be Dr. Sekera Makusa. She's a pediatrician, and currently she is Executive Director for EGPI Tanzania. Karibu. So you see, ile shida ya mwanzo haipo sasa hivi. Unaiona? Kuna representation. Yeah. So as I mentioned, we are going to discuss about how to better reach key and vulnerable populations and strategies forward to increase the treatment adherence in our context. So I would like to start with Dr. Isaac Maro. Bearing your experience of working in a public health, I understand you have been a clinician for a very long time, working for different researches in the country. What are your opinion and perspective in attitude of healthcare providers when it comes to provide SRH and HIV services to KVP and people living with HIV?
Thank you so much, Dr. Katanta. To begin with, I think this is a very important discussion because for us to move forward, we really have to take a really deep look into how we give our services specifically to key and vulnerable population. And to just start, I would like to just say, first and foremost, a healthcare provider is a very important person in terms of when it comes to care and treatment. So one thing that we have to start from is we have to make sure that that care provider understand who is the key and vulnerable population and accept. So now we have to go back to the acceptance. So we begin from there. And from our previous and many discussions we've had in the past, we always like to ask this question: are you willing to give services to a key and vulnerable population person? And that starts from a service provider, from a doctor, from a nurse, from a counselor. Are you willing to work with a key and vulnerable population? Now we start from there. So for me, I would like, of course we'll discuss further, but for me, I will start with this first question. Are you or am I willing to give services or to give care to a person who belongs to a key and vulnerable population group? So that will start from there.
Okay. So, thank you very much, Dr. Isaac. So let's hear now from a youth representative, Josephine. How do you feel the strategies will include KVP in remote places where with minimal stigma and discrimination?
I mean, when you talk about stigma and discrimination, it's about what someone believes. It's about the minds of people. So if we are to really see any change, if we are to really see any positive impact, it comes to how do people feel, how do people think. So each strategy or each activity or anything that we need to do, it should be really targeting, shifting the mindset of our people in the community, but also ourselves. I mean, we've been in positions where you're talking about something, but you yourself, deep down within yourself, you're actually doing the same thing. So it comes back not just to the target audience, but also to the people themselves that are targeting or creating the change that they need to see.
Okay, thank you very much. Can you applaud a youth representative, and can you also applaud Dr. Isaac? So now I'll go to the government representative, to my brother, Dr. Nsumba from TACAIDS. What role does the government, or could the government, what role should the government play to freeze stigma perception in new innovative strategies?
Thank you, Dr. Simwanza. I think it's a very critical question that has been coming up in different occasions. And as you may remember, early in the morning when I was making my presentations, one of the key results that we want to focus as a country is to have zero stigma and discrimination, because we appreciate that stigma and discrimination affect our programs, be health services utilization or HIV and AIDS utilization of services, but also treatment outcome. As we have just heard from my sister from Kigoma, the way this young boy was affected by stigma, leading him to not getting proper treatment. So, as a government, there are strategies that are being put in place to try to address the issue of stigma, in particular in the sense that we wish to ensure that people are getting services. You may recall, and you can attest to this, there's been a number of programs, especially to work with law enforcement agents, the police and the judiciary. There have been programs to sensitize them to understand the approach, the public health approach to the HIV response. But of course, as you may agree with me, this changing of attitude takes time. These are not one-time events. So, but there are mechanisms in place, and we are continuing to address those issues, and programs are ongoing, including the issue of gender. You may be aware, currently there is a gender desk in every police station. So those are the initiatives trying to address all of those things that are really pulling us back in the HIV response. But if you go at the community level, for those who have been working with community organizations, you may recall during the HIV response, the multi-sector response in the early 2000s, the government through TACAS established the so-called multi-sectoral AIDS committee. And the essence of those committee is to create a platform at the community level where the community can engage in dialogue about the HIV response. And some of the things that are being tabled in those discussions, I thought that really pulled down the response, things like stigma and discrimination. But I would say it takes time to change attitude and to change the way community look at things. But, well, you may, but also, I think we need also to invest in some community programs, like community awareness programs through the media, be it television or the radio, though that are context specific. I hope you're getting me. Because HIV has become a chronic but manageable disease. So we really need to make people understand that and be able to provide services without any discrimination, including testing, but also prevention programs, but also those who are found infected can also have access to HIV care and treatment. In line with this, the government is also continuing building capacity of healthcare workers to be able to provide services free of discrimination and stigma to the population. The other thing that the government has done, especially in the public services or public institutions, but also we have scaled up in the private institutional organizations. We have these workplace programs for HIV, where we make HIV an agenda, and we encourage people to come up with services, and like they are given services like HIV testing programs, and those who are found positive are linked to programs of care and treatment. But also they are supported in a way to navigate through some financial difficulties, to support them in terms of nutrition. But all of those kind of interventions are meant to really deal with the issue of stigma and discrimination. Less people change the attitude towards AIDS and HIV, but also services. And if we are able to address the issue of stigma, I believe even those bottlenecks that we see in our programs will be reduced significantly.
Thank you very much. Thank you very much. We are proud, Dr. Sumba. Yeah, so we have heard about the involvement of young people, the perceptions of service providers, how can it transform the uptake and utilizations and provisions of health services, especially for KVP and people living with HIV. Together with the government commitment, especially by working with community engagement structures, law enforcement and police gender desk, how can influence and push forward the agenda. So let's now invite my friend, Arnold Nicholas from KVP Forum. I would like to know or to hear your opinion in what is the best way to engage the KVP in a new innovative approach on ending HIV. Okay. What is the best way to engage the KVP in a new innovative approach on ending HIV? How should we engage a KVP on using innovations in prevention of HIV or in ending of HIV?
Thank you very much. For me, I would say the KVP themselves have to be, we KVP ourselves have to be part and parcel of the designing and implementation of the entire thing. Because sometimes you have programs that are running and they have the component of testing and, you know, taking people to access medication after testing, or if they're HIV negative, they have to go on PrEP or comprehensive condom programming. But sometimes the way that these people are reached is not actually translating to how they are actually engaging as key and vulnerable populations. So we have types even in the KVP under the KVP name itself. We have sex workers that are on the side of the road. We have sex workers that do their sex working online. We have other, let's say, MSM who live in I don't know what's the word for. We have MSM living in those areas that are not so privileged. We have MSM that are very privileged. We have MSM working in the government. We have MSM working in the hospital, everywhere. So these people are never going to be reached by the same approach. You are not going to find a person who works at an office at a hotspot where you can test them for actually giving them services, or you're not going to find sex workers that do sex work online. You're not going to find them on the side of the road or at a hotspot where you're going. So in the designing of these programs, there should be an area where the actual beneficiaries are part of the process and they can actually translate what they want or how they would like to be reached. Or if we are trying to do this thing holistically, then we can make sure that we are reaching everyone. We are reaching not just a certain type of people, or not just those KVP who are found on hotspots, but we are also reaching other KVP that are not found on hotspot and are actually in need, or actually need the awareness that all these other people that are getting.
Thank you very much, Arnold. Can you applaud him? So now let's hear from a pediatrician, Dr. Sekela Makusa. How to better reach adolescent and young women and strategies forward to increase treatment adherence.
Asante, Dr. Katanta, and thank you for that question and for the opportunity to share what I think. So, as we have been hearing from morning, young people, particularly adolescent girls and young women, is the group that is most affected by HIV in many ways because of, actually you can say they're disproportionately affected compared to any other group. So that is because of their vulnerability, which I think we are aware of. And so I think, so that I'm very brief, I think the most important thing that we need to do is to make sure that these services are made accessible and convenient for them. And one of the things that we can do is to make sure that we provide adolescent and youth-friendly services, particularly in the health facilities where they come. Because usually that is the first place that adolescents will come and young women will come to receive services, be it for HIV testing, be it sexual reproductive health, and all these other services that they require. So if we are able to provide these adolescent-friendly services, adolescent and youth-friendly services, that are integrated in one place, then we will be able to reach them and make sure that they are there and they get the treatment properly. And we can do that by making sure that we train the providers, as Dr. Isaac was starting to tell us. We train the providers so that they are able to, they acknowledge that this is a group that requires differentiated services, and they are ready also to provide the services. Another thing that we can do is to address the stigma issue that is making this group refrain from coming up for services. We know that many adolescents and young women are unable to access sexual reproductive health services, mostly because of the attitude that they receive from their providers. So if we work on stigma issues that we've been hearing since morning, I think that will also help. One thing that I learned today is I know about meaningful involvement of these groups, but I think, I don't remember the name of the gentleman who talked about ethical and meaningful involvement of the adolescent girls and young women, particularly in designing of these interventions and also implementation of the interventions. I think this one will help us to understand what are the needs and make sure that they participate in the interventions. And this, we have seen it works very well. We had a program that we were working with youth, and we trained peers, and we found that they really helped in making sure that these girls are tested and they are getting treatment, and they also adhere to treatment. Asante.
Asante sana. Can you applaud Dr. Sekela? Yeah, so young people, especially adolescent girls, is a special group which as a country need to do a lot of investment. As we are speaking from the previous statistics, Dr. Wena has mentioned that soon we'll be having new statistics, but currently we know out of 4.6, almost 2.1 of the populations who are living with HIV are adolescent girls. If we told you 4.6 to 2.1, ni asilimia ngapi? Yeah, that's why we do consider in the KVP definition adolescent girls to be one of the group in which need special attentions. And some of the factors which are contributing to them to have high prevalence, as we started in the morning, we talked about the stigma and discrimination issues, lack of skills for service providers. Those are some of the barriers. But our personal perceptions and attitudes, like what Dr. Isaac was speaking, can contribute a lot in accessing of service provisions and utilization of the services. So, let's have some ideas and reflection from you. Kama mna maswali, if you have any follow-up, suggestion, comment, and then later on we'll give the opportunity for our panelists to speak out. Okay. Anza kule mwisho kabisa kwa Cloud.
Okay, my name is Claudio Sengers. I wanted to contribute from what Arnold, as part of KVP Forum, I said, from my lesson learned after Arnold, that we have guidelines, national strategies that only has been designed because of a key population in a certain risk, and not all key populations. You can say, for instance, we design a guideline for queens, but you target queens who are maybe on the street or in a certain place, and would not cover queens who are found even in offices and different places. Likewise to fisheries, likewise to trans, likewise to MSM, likewise to sex worker. If we can have a guideline, we need to have a comprehensive mapping of key populations on their hotspots, their availability, so that we can have comprehensive documents that accommodate everyone. Thank you.
Asante sana. Mpe jirani yake mkono hapo, huku kaka kwenye kona. Na ikiwezekana unaweza kusema specifically, if it's possible, just say straightforward kwamba this question you are targeting panelists which, yeah.
Okay. Good afternoon. My name is John Bosco Basso from FHI 360, Senior Technical Advisor, SBC. I will comment on Dr. Isaac's presentation. And Dr. Isaac, I don't know whether you have conducted what we call social norm exploration in regard to what are the biases and what are the attitudes that come from the community members, but I want to focus on service providers. Service providers, sometimes we think because they have gone to trainings, they have received counseling, training, we think they are much better placed to serve key and vulnerable population. But to be honest, service providers, they have their own biases. And in behavioral science, currently we have what we call PBC, Provider Behavior Change Communications. And there are tools that are very specific to training service providers on addressing their biases, owning their biases and reflecting on their biases and be ready to change to serve different groups of the population. Can be adolescent girls and young women. It can be KVPs. So I just wanted to comment that there is these modules which we can use. One is the norm exploration tool, which we can use to explore the norms that pose barriers in provision of services by service providers, but also the deep-rooted social norms that cause stigma for different groups of population, especially in access to services. Not only HIV services, but also we have seen this, also the bias for family planning services among young people, especially adolescent girls and young women or young mothers. So it's not a question, but I just wanted to comment on how we can build on existing scientific tools to address barriers to services. Asante.
Thank you, Basso. Thank you, Basso. So let's have there, then here, and lastly, the last person will be.
Thank you to our panelists. My name is Elizabeth Senkoro. I'm from the Ifakara Health Institute, but I'm also a Mark Weinberg Fellow from IAS. And I have a comment on changing mindsets on stigma and discrimination. I was wondering if we can partner or engage the Ministry of Education and somehow change our curriculums in primary, secondary schools, and also universities. So we have these books and we still have pictures of a person living with HIV depicted as this person withering away, but how can we change mindsets when we have our kids and children in school seeing these pictures and they grow up later to become service providers? So that would be one way to explore. And just here from my fellowship, last year I was in Uganda, and when they started rolling out PrEP, with a special consideration to KVPs, there was a lot of resistance from healthcare providers, and they had to carry out like nationwide training, retraining, so that we can relearn. We have new evidence, so maybe countrywide retraining of people, that would also help.
Thank you, Rafiki. Tumalizia wawili kosi. Pale nimeshakuona. Nimeshakutetea watu. Asante.
Okay, my name is Elizabeth Nsuya. I work with Focus for the Future Generation 12G. Okay, I will quick comment on Dr. Sekela's okay. I want to add something. First, to better reach key and vulnerable population, we must first acknowledge, fully acknowledge them. I remember in the past we have a seminar and we invited a registrar of NGOs, and he told us, if I will have a request of NGO that is on their objectives, they mentioned something like, no one will left behind, key population, I will not register such kind of an NGO. So there is, let's say anyway, thank you.
Yeah.
What I wanted to say is, most of government officials, law enforcers, and policymakers didn't have better knowledge, wider knowledge about KVPs. They point as one among the anyway, thank you so much. Okay, kwa Kiswahili, nafikiri kwa sababu I'm little
just go on,
yes.
just go on.
Okay.
Yeah, it's okay.
Nilikuwa nataka kusema hivi, wanaelewa Kiswahili. Nafikiri wakati mwingine kwenye conference hizi na meeting kama hizi ni muhimu sana kualika watunga sera pamoja na watunga sheria, kwa sababu si mmoja tu, hata maregistrar wa NGOs, kwa sababu tuli experience ni kundi ambalo halijulikani vizuri. Alafu nikajaribu kutoa mfano, tulikuwa na seminar, tukamwalika msajili wa NGOs, akatuambia kwamba nikikutana na NGO yoyote ambayo kwenye objective zake kuna kitu kama key population, no one will, yes, sitasajili aina hiyo NGO. Kwa hiyo tayari discrimination inaanzia hapo, kwa sababu kuto kufahamu tu kwamba nini maana ya KVP, wanafanya nini kama hiyo. Hicho ndio tunataka kuchangia. Nafikiri kwa sababu kidogo nina hofu, that's why, lakini
nashukuru. Asante. So she's speaking about one day they organized a meeting and they invited the registrar of NGOs, and he told them, if I find in your organization one of the objective is either you're speaking about key and vulnerable populations or mentioning something about leave no one behind, you will be deregistered. Okay? If you are registered, you will be deregistered. And if you want to be registered, you won't be registered. So, yeah. So the advice she's making is that next time when we are organizing such kind of meeting, we have to make sure that we invite all key actors, especially the law enforcers, policymakers, na hao wao wengine wote, so that they can participate to better understand. Because one of the cause of the behavior is because of stigma and discrimination, attitude, norms, na vitu kama hivyo. Kosia, can you go ahead? Thank you. Dada.
Thank you very much for the opportunity. I just wanted to contribute what we have done in the project in relation to adolescent young girls and women. And as we said, we understand that those are the key population because they are more likely to not to adhere to ARV, taking into consideration of changes of physiological changes in their bodies, and they are associated with a lot of stigma, discrimination, and gender-based violence. We recruited them and they trained as mother mentors, and we developed together with the community development officers, psychosocial and income group. What does psychosocial do? Psychosocial group, they form as a group for their counseling and their reliance. And they also link to income generating activities, because we understand that poverty in line with the ARV or being HIV positive is always associated with a lack of detention, poor detention in ARV services. So what I want to say that we have seen that most of them being in income generating activities, we have seen them in detention. And most of them, because we train the mother mentors, they have developed confidence, they are able to adhere to counsel their other colleagues, and they are able to be in a group, and they stop stigmatizing themselves. So I was recommending, because we have government officials, and in the future future plan, we should integrate psychosocial income generating activities because it has an impact in relation to detentions and reducing stigma and depression among the adolescent and young girls. Thank you very much.
Asante sana, Agnes. Last three, okay. Bahati should be the last. Sir. Karibu.
Asante. My name is Christine Peter. I'm the Executive Secretary of KVP Forum. For me, I would love to add wherever Arnold was talking about meaningful engagement of key and vulnerable population. Our government has has done tremendous work. We have great policies on KP interventions. We interact with them, we work together. But I would really like to recommend to the government of Tanzania concerning key population interventions. We should not overlook or just pick and choose what to do. We should embrace each and every key population member. For instance, in our previous KP guideline, there was the inclusion of the transgender people, but there was no program that was designed for the transgender people. So we should not just say, okay, we can do this and leave that, because we understand that tunaingiliana. Kwa hiyo you may design a program for a certain person and leave the other person, but in one way or another, you will intervene. That is one. I would also want to contribute to Dr. Sikela on the issue of the adolescent girls. You mentioned that adolescent girls, the first thing they would think when accessing services, they would go to the health facilities. I mean, we've all been adolescents. We understand adolescents, when it comes to the facility, that is the last option. We should start thinking of other ways. Where are we going to reach these adolescent girls? You're not, actually I'm an aged woman. I am a young mother. Yeah, I was an adolescent mother. And I know I used to get advice from my colleagues, from my friends. Back then we didn't have social media, but right now there's social media where adolescent girls, even us, we engage so much in the social media. So you should really, really reconsider through that spectrum. Thank you.
Asante sana, Joy. Karibu Bahati, msemaji wako.
Thank you. My name is Bahati Mandago from Integrative Wellness Services Company. It's a private company, but I'm a counselor. Actually, I would like to speak briefly about stigma and discrimination. To me, stigma and discrimination is very wild. Often it starts within. I used to have a friend, actually I still have him as a friend. One day he told me, Bahati, are you okay with me the way I am? And I said, are you okay with yourself? He never answered me. So this is very important. I think our mind as a human are very complex. We live in denial. Sometimes you get a result like, let's say you're HIV and AIDS positive, and some people stay in denial for 10 years. So how can people around you accept you if you haven't accepted yourself? Okay, let's say if somebody comes to me and say, hey Bahati, you look elegant, you look beautiful, and I don't feel beautiful myself, and I don't believe I'm beautiful. Will that make sense? So I think we should also invest so much within people themselves, within vulnerable groups, like to help them to become okay with their status, to become okay with who they are. Because the moment you have accepted yourself, you're very much equipped internally. It's very easy to overcome anything outside. Because I know that you can lead a cow to a river, but you can never force them to drink water. It's I think to me it's always impossible to change people's perception. It's unless you change yourself first. So just to emphasize, the stigma and discrimination subject is extremely deep and it's very complex, but it has to start within ourselves. Thank you.
Asante sana. So but she's telling us changes should start with me. it should begin with me. Karibu. So for our panelists, you have 2 minutes each, and you will start with Dr. Sekela. Karibu.
Asante. Thank you, Dr. Katanta, and every one of you that has contributed to the discussion. And I agree with Christina about where to find the adolescents. And I know the spectrum has changed, so I completely accept and agree that we need to find adolescents where they are. The hospital or the health facility would not be the first place to be, but at least if we have people that can receive adolescents at the facilities and provide the services they require, we would be in a better place. But I agree with you definitely that we need to find adolescents and young women where they are. There was also another comment about mentor mothers, which we accept. Thank you. 2 minutes over.
Thank you. Asante, tumpigie makofi dada yetu jamani. Asante, karibu. Anot.
Asante sana. My comments are as follows. I think number one, we have to reduce the stigma around HIV and around the KVP name themselves. I remember there was one time we were at the World AIDS Day. It was in Kilimanjaro, if I'm not mistaken.
Yeah, the other way.
Yes, so there was one person from the government who didn't like the way we framed the word KVP. So it became an issue. So you can see there is still stigma around those groups. And I feel like that's the first thing that we have to also address if we want to have a holistic approach. Number two, I think, and this might be far-fetched, but I think it's something that can help. If we decriminalize these groups, they are more likely to come out and access the services. Sometimes these people don't want to come out and access the services because they know there is stigma on who they are. They know that they have a conflict with the law. So when that is the case, it's also difficult for these people to go out and say, I want to access that services, because how can they if they know they're considered as criminal? So making this a crime is also part of the problem, that it attracts more stigma to the people. Number three, I think we should reinstate dropping centers. Dropping centers where they were not offering ART at the moment, but they were a place where the KVPs can come and find friendly services like education and many other things. So I think it's important if we can consider having that discussion on how that can look like in order to have a holistic approach. Thank you so much.
Asante sana Anot. Karibu, Kenya.
Thank you so much. Someone from the audience talked about mentor mothers and psychosocial support, and I want to start from there because I was once a peer educator at one facility. And the question that really comes back is, who is supporting me as a peer educator? Who is supporting me as a mentor mother? So as we think of maybe coming up with integrating psychosocial support, because as soon as you talk about psychosocial support, you're going to look at who is going to provide it. And definitely you're going to identify the peers themselves to provide it. So we need to also be mindful of who is providing psychosocial support to these psychosocial providers. Because at the end of it all, they are going to face the same realities their peers are facing. I mean, we've seen young people support other young people to take their medication, and then in the long run, someone also dies because of, stopping to take their medication. We don't want to have such cases when we involve our mentor mothers or our peers in service provision, but then in the long run, we don't actually support them to receive the same care and the same support that they are giving out. Still about stigma and discrimination, I think we need to be very inclusive, not just of certain sectors, but of everyone. Sometimes I find that in our HIV space, sometimes we keep things within ourselves too much. You go to a facility and there is a psychosocial support meeting, and it is only for people or children or adults that are HIV positive. And guess what? You're talking about you equals you. But the same information is needed out there to those that are HIV negative. So I think sometimes we keep the information and so much within ourselves, yet actually it is that same information that's going to fight the stigma and discrimination that we are facing out there. And lastly, someone talked about meaning about self-stigma, meaning about what someone thinks about themselves, which is important. But also we should mean about what the environment around us thinks, because sometimes, should I say, stigma is learned? Like, who grows up knowing that having HIV is a bad thing? You know, you just grow up and before you know it, you know actually it is a bad thing. Like, you just now get all those negative.
Try again.
Was that a warning that my 2 minutes are done? Anyway, I think I can be a bit audible. So as I was saying, sometimes stigma is learned. So as long as we look at what someone is feeling, it is also important to look at what is surrounding that person. Because our young people will learn. We learn from the older people around us that maybe this is bad and that is bad. And definitely also, as someone said, what is taught at school? Do we still have those images that show someone is just, you know, slim and all those things about HIV? So I think stigma, discrimination, sometimes it is learned. So it is important as we look at an individual as a person, we also look at what is around that individual and how can we penetrate all those kinds of surroundings to those people, because they will learn how to stigmatize and they will learn how to discriminate, not just themselves, but also the other people around them. Thank you.
Asante sana. Tumpigie makofi jamani. Yeah. Now, when she was speaking about when we were making more focus for adolescent girls who are positive and forgetting those who are negative, she reminded me one thing. In our empowerment program, and particularly for when we are addressing HIV program, for HIV programming, we are giving more focus for adolescent girls and we are forgetting a boy child. So it's high time now we turn our reason to start considering a boy child as well, because where as these adolescent girls they are getting infected, some of the infections they're getting from their peers. You see? So as a country we need to make a reconsideration and start investing now more on both adolescent boys and adolescent girls. Asante. So Isaac, karibu. Naamini sauti yako ni
I hope so. Can you hear me?
Yes.
Yes. All right, good stuff. First, I would like to just congratulate everyone, because I think all the ideas and all the inputs have been positive. I would like to go back to us care providers. I really think that because we're in the same society, as Dr. John said, we are the product of the same whatever environment. So if the society has, is divided into, do I accept KVP or do I not? Am I socializing with them or am I not? Doctors and nurses and care providers, they're all the same. We're all coming from the same community. So I would like to start with is, for us care providers, we need to go back to the oath, whereby I will treat my fellow human, I will give him the same care that I would give any other person. So maybe we should stick to the oath first. And second, I'm really having trouble with, we have a lot of discussion, we've been talking a lot here, but we know that there's a big elephant in the room, which we know that our government does not really, KVPs are not all KVPs are recognized. We know that. We are trying to figure out ways to go around and round and round and round to care for those who are not really be recognized by the government. I think we have a responsibility to, as she said, we need to have people who are making policies. We need to have government people in our meetings. We need to tell them that, if we're not taking care of them, no one is safe. So I think it's very important for us to also start including those who are making decisions. And also, I really think, I'm going back to the adolescents now. I said earlier that we are really addressing adolescent girls, adolescent boys, but we are not really doing something about it. The political will is there, the numbers are showing, but we are not really addressing it. So I'm going back to her point that if we are to wait for adolescent girls and boys to come to the hospitals, to come to the facilities, then we are missing the whole point. We need to follow where they are. If they're in the social media, then we go to the social media. We need to be innovative. We need to find ways to address our kids, to address our adolescent young boys and young girls, and to tell them how they can take care of themselves, how they can protect themselves, using their own ways. This is what we are missing right now. We are saying that we are forgetting a boy child. Yes, we are doing that. We are saying that we are trying to address the young adolescent girls and young women, but we are addressing them wrongly. So probably they are not hearing us. I'm in the radio. I know that if you ask a child today, 14-year-old, about HIV, deep like the education that we got, they don't know anything. Because they can't. They are listening to Singeli, they are listening to songs, they are everywhere, but the hospital. We are giving our education at the hospital. They are not there. So we have to find a way, innovative way, to have a girl child participate. We have to have a way to have a boy child participate in these meetings so that they can be peer educators, so they can educate other young boys and young girls. And that way, we can really, really get to where we want to go, where we really are focusing. So this is all I'm saying.
Thank you, Dr. Ida. Any applause, Dr. Ida? So the considerations of other KVP subgroups which are not recognized in your guidelines, standard operating procedures, and legal definitions ni ya muhimu, is of paramount significance. Sasa serikali, karibu uongee. Dr. Sumba. Yes.
Yeah, my many thanks to the audience. All of the comments have been really very effective. But I just wanted to make a follow-up of one because of the time. And this is from my sister from Fakala. The issue of changing mindset. I think it's very critical that we start somewhere if we want to be forward-looking. Yeah, much as we are struggling with these short-term kind of interventions, but we should really maybe engage also the ministry of education so that we can have those curriculums including this kind of intervention.
And just for information, it has started, especially for the vocational trainings. Hata ile mifano anayezeka si ni mwanaume sasa hivi ni mwanamke anayepiga yani imechanganya. So it has started. And last year, I think around November, there was a launching of packets are here. Yes. A comprehensive sexual education manual, which will be trained, which will be used to taught students in primary school and secondary school. Yeah, so please come over with Karim.
Yeah, thank you. Yeah, I was just trying to think about having interventions that are permanent for our issues. The same thing, I remember the other time I had an audience internationally, the director of tax education about the tax compliance in your budget. I told him, why can't we engage with this ministry of education? But we have those kind of teaching right from the beginning so that our kids grow knowing that if you're not paying tax, what are the consequences? Rather than bombarding information into this other already message.
Yeah, sure.
Yeah. They want to avoid tax all the time.
Yeah, we call it life was your plot.
Yeah, exactly. Children is the way to go. You have to start from there.
Asante. So thank you very much, panelists. You see, it's very important for all of us to be on the same place. The government, the private sectors, the target audience, you see, to discuss and address all of these issues. And I need John Bosco, we'll really appreciate if you will share with us the social norms exploration tool, because it's very important. Especially, she's talking about retraining and retraining. That's very important also. The provider share training are of paramount significance, especially in our program. Every key actors who is working in a different perspective, different thematic areas, we need to consider to conduct such kind of training. I understand Turkeys are doing a lot of trainings along the stigma and discrimination issues. And they're really encouraging the civil society to do so at the end of the day. So thank you very much. A round of applause for all of us. Where our panelists are going to sit. And now taking it back to Professor to tell us what is next. Asanteni sana. Tunatokia makofi.
Yes, we put on my microphone. Yes, thank you.
Thank you very much. I think that was a great session, and we really enjoyed listening to all the panelists and the excellent sharing. So now we have a 15 minutes tea break, but I would request that we make it 10 minutes so that we stretch before we come back to the group session, group work session. And in this group work, we will introduce it, and Dr. Kantata Simwaza will take over. So let's take a 10 minutes and get back here at 16:24 so that we're able to go home in good time.